Hi friends, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in emergency medicine. In this video, we are going to discuss about hyponatremia, starting with the definition of hyponatremia. Okay, hyponatremia is defined as sodium concentration less than 138 milliequivalents per liter. Okay, moving on to the classification, hyponatremia can be broadly divided into three different classes. Okay, first one, it is based on serum osmolality. Okay, based on serum osmolality. Okay, three different classes. First one is hyperosmolar. Then isoosmolar. Then hypoosmolar. Okay, hyperosmolar hyponatremia, if the serum osmolality is more than 295 milliosmol per kg of water. Okay, and isoosmolar if it is between 275 and 295, and if it is less than 275, serum osmolality is less than 275, it is hypoosmolar. Okay, now the examples of hyperosmolar. Example of hyperosmolar is nothing but it is seen with severe hyperglycemia. Okay, it is seen in hyperglycemia. Okay, what happens in hyperglycemia is that for every 100 mg per deciliter increase in blood sugar, okay, in increase in glucose will leads to a decrease in sodium, decrease of 1.6 milliequivalent per liter decrease in sodium. Okay, for every 100 mg per deciliter increase in glucose level above the normal level. Okay, please note it is above the normal level. Okay, will cause a decrease in sodium concentration by 1.6 milliequivalents per liter. Okay, that is the example for hyperosmolar hyponatremia. Now isoosmolar hyponatremia is seen in, the examples are high concentration of lipid, okay, increased lipid concentration or increased protein concentration. Okay, these two conditions will lead to isoosmolar hyponatremia. Okay, this hyperosmolar and hypoosmolar, these two conditions together named as pseudo hyponatremia. Okay, there is no true hyponatremia, it is pseudo hyponatremia, because here the hyponatremia is because of increase in the concentration of other components. Okay, now hypoosmolar hyponatremia, this one it will refer to the true hyponatremia. So let's discuss about hypoosmolar hyponatremia. Okay, moving on to hypoosmolar hyponatremia. This hypoosmolar hyponatremia further divided into three categories based on the volume status. Okay, based on the volume status, it is further divided into three categories. Previously, we categorized the hyponatremia based on the serum osmolality. Now, the third class of hyponatremia, that is hypoosmolar hyponatremia, is further divided into three groups based on the volume status. Okay, so first one is hypervolemic. Second one is normovolemic, and third one is hypovolemic. Okay, the examples for hypervolemic are congestive heart failure, liver cirrhosis, nephrotic syndrome, and AKI or CKD, acute kidney injury or chronic kidney disease. Okay, these are the examples for hypervolemic true hyponatremia. Okay, now normovolemic hyponatremia include glucocorticoid, glucocorticoid deficit. Okay. It is seen in SIAD. SIAD is a classical example for normovolemic hyponatremia. Okay. And also polydipsia. Okay. Moving on to hypovolemic. In hypovolemic, we have diuretics. Okay. By ingestion of diuretics, mineralocorticoid deficit. Okay, glucocorticoid deficit will leads to normovolemic, while the mineralocorticoid deficit leads to hypovolemic hyponatremia. Then salt losing nephropathy, salt losing syndrome. Okay, also vomiting and diarrhea. Okay, these are the examples for hypo-osmolar hyponatremia. Okay, moving on to the clinical features. Clinical features of hyponatremia. Clinical features of hyponatremia can be again broadly divided into two groups: moderately severe and severe. Here we have moderately severe, and here we have severe. Okay, the symptoms of moderately severe hyponatremia begins at a sodium concentration less than 130 milliequivalents per liter. Okay, and the symptoms include headache, can be present as headache, nausea, disorientation, confusion, agitation. Okay, and also reflexia. Okay, these are the clinical features of moderately severe hyponatremia. While the severe symptoms of hyponatremia will start at a sodium concentration below 120 milliequivalents per liter, and the symptoms will be like intractable vomiting, seizures, and patient might be in coma, or ultimately respiratory arrest due to brainstem herniation. Okay, can go for respiratory arrest due to brainstem herniation. And these category of patients, that is patients with severe symptoms, are candidates for treatment with 3% saline infusion. Okay, they have to be treated with 3% saline. So moving on to the management part. Okay, management of hyponatremia. In management of hyponatremia, there are two parts. First one is correction of water imbalance. Correction of water imbalance, especially in case of hypovolemic hyponatremia. Then go for correction of sodium imbalance. Okay, so the first part for the correction of water, if there is no water excess. Okay, if there is no excess water, that is in hypovolemic conditions, hypovolemic hyponatremia, we can give normal saline for making the body's water to normal level. Okay, and then consider about correction of sodium imbalance. So during sodium imbalance, for chronic hyponatremia, the correction of sodium should be slower than correction for acute hyponatremia. Okay, this is because the adaptation mechanism of brain cell. Okay, let us discuss what happens to the brain cell in case of a hyponatremia. Suppose this is the normal brain cell. Okay, normal cell, and there is an hypovolemic hyponatremia, acute onset hypoosmolar hyponatremia. That's a true hyponatremia. Okay, so definitely the fluid from the extracellular space will enter to the cell. Okay, so the cell get swollen. There will be a swollen cell. Okay, but what happens if this hypoosmolar hyponatremia persists? If there is a sustained hyponatremia, there will be some adaptive decrease in cell volume. Okay, not become normal, but the volume will be decreased than from the swollen state. Okay, so there will be adaptive decrease in cell volume. There will be adaptive decrease in cell volume. So this is a chronic hyponatremia. Now it become chronic because there is a sustained hyponatremia and there is adaptation also. So what happens if we are acutely correcting the hyponatremia? So rapid correction. There will be shrinking of cell and there will be lysis or demyelination in brain cells. Okay, there will be shrinking of cell shrinking in rapid correction. But for a slow correction, the cell volume will be restored. Okay, so the cell will become normal cell. The swollen cell now became the normal cell. So this is why we should correct chronic hyponatremia at a slower rate than the acute hyponatremia. Now, how to correct the hyponatremia? As we already said, we can use NS normal saline, 0.9% saline for patients with for true hypovolemia and hyponatremia. But if there is symptoms of severe clinical features of hyponatremia, we can give 3% saline. Okay, now how to correct with 3% saline? Okay, using 3% saline, how to correct the sodium deficit? For that, we have to calculate the sodium deficit. Okay, so the formula for calculating sodium deficit is desired sodium minus serum sodium, okay, into 0.6 into body weight in kg. This is the equation, and you have to remember one thing. For a acute onset hyponatremia, you can correct 12 milli equivalent per 24 hours for an acute onset hyponatremia, and you can correct up to 6 milli equivalents in 24 hours for a chronic hyponatremia. Okay, this should be keep in mind while calculating the sodium deficit. Okay, so the correction for chronic hyponatremia should be slower. Okay, so let's do one example using this formula. Suppose you have a 50-year-old male weighing 70 kg. Okay, presented to your emergency department with altered sensorium and a seizure-like activity, and his sodium found to be 110 milli equivalent per liter. Okay, and the symptoms within a one day duration. Okay, now there is not, he is not fluid overloaded also. So the patient was presented with the symptoms of severe hyponatremia. So we have to give 3% saline. So for that we have to calculate sodium deficit. Okay, so in this patient we can go up to a maximum of 12 milliequivalent increase in sodium within 24 hours. So we are desired sodium is 110 plus 12, that is our 122. Okay, minus the current serum sodium is 110. Okay, desired sodium we obtained by adding 12 to the present value. Okay, into 0.6 into body weight is 70. Okay, this is 12 into 0.6 into 70, and it will be equal to 504 milliequivalents. Okay, so the sodium deficit is 504 milliequivalents. Now the thing is 100 ml of, the fact you should remember is 100 ml of 3% saline will give 51.3 milliequivalent sodium. Okay, so for correcting 504 milliequivalent we need xml. Okay, xml is needed for 504 milliequivalents. By solving this mathematical equation we will get that 980 ml, 980 is equal to 980x will be equal to 980 ml. So 980 ml of 3% saline is needed to correct 504 milliequivalents of sodium deficit. So we can give 980 ml in 24 hours. Okay, in 24 hours, because we calculated this sodium deficit by taking 12 correction of 12 milliequivalent in 24 hours. So we should give 980 ml in 24 hours. So the rate of infusion should be 980 divided by 24, that is 40.8 ml per hour. Okay, this is how we have to correct our hyponatremia with severe symptoms using 3% saline. Okay, I think the concept is clear. There is one more strategy for correcting hyponatremia in patient with seizures or coma. Okay, so treatment in patient with seizures or coma. Okay, because of hyponatremia. Okay, so the first step is you can give 100 to 150 ml of 3% saline over 15 minutes. Okay, after that you have to check serum sodium level. Okay, and you can target an increase of 5 milliequivalent per liter. Okay, if there is no increase, if the serum sodium level is not increased up to 5 milliequivalents per liter with 100 to 150 ml of 3% saline, you can give a repeat dose. Okay, you may repeat 150 ml of 3% saline to achieve an increase of 5 milliequivalents per liter of sodium, and you may repeat up to 3 times. Okay, up to 3 times total dose, or a total of 450 ml of 3% saline. Okay, this is another method for correcting sodium deficit in patient presenting with a hyponatremic seizure or coma. Okay, first you have to infuse 100 to 150 ml of 3% saline over 15 minutes. Then you can check the serum sodium level. If it is not increased up to 5 milliequivalents from the baseline value, you can repeat a total of 3 times. Okay, of 150 ml of 3% saline. Okay, this is the another method. Okay, now what happens if you are rapidly correcting the sodium in a chronic hyponatremic patient? Okay, it is nothing but it is osmotic demyelination syndrome. Okay, so it is caused by rapid correction of sodium if the patient is presenting in an acute setting. Also, if we are correcting more than 12 milliequivalents per 24 hour, it will also leads to osmotic demyelination syndrome. So caused by rapid correction of sodium more than 12 milliequivalents per 24 hour. Okay, what happens is fluid moves from cell to ECF, extracellular fluid. Okay, fluid from in the intracellular compartment will move to extracellular compartment, lead to intracellular dehydration, leads to intracellular dehydration. Okay, so now about the risk factors. There are certain risk factors which increases the chance for osmotic demyelination. So the risk factors include if the initial sodium value is less than 120, okay, or if the patient is having chronic heart failure, cirrhosis, underlying liver disease, or if the patient is alcoholic. Okay, these are certain risk factors associated with the osmotic demyelination syndrome. Now moving on to the symptoms or clinical features of osmotic demyelination syndrome. It includes dysarthria, dysphagia, lethargy, okay, paraparesis or quadriparesis, or it can even leads to seizures or coma. Okay, these are the clinical features of osmotic demyelination syndrome. Now moving on to the treatment of osmotic demyelination. Okay, you can give either a 5% dextrose in water at a rate of 3 ml per kg per hour. It's a one option. Or you can give loop diuretics, or you can go for desmopressin. Okay, so these are the treatment options for osmotic demyelination. Now our discussion on hyponatremia will not complete without discussing about SIAD or syndrome of inappropriate ADH secretion. See a few words about SIAD. So the causes for SIAD. Okay, just about the causes. Causes can be either neurological, and the neurological causes include your infections like meningitis or encephalitis, okay, or brain abscess, traumatic brain injury, malignancy. okay, primary or metastatic malignancy of the brain parenchyma. Now the other causes include drugs. Certain drugs can increase the risk for CIAD. Drugs include cyclophosphamide, carbamazepine, carbamazepine, SSRIs, SNRIs, amiodarone. Okay, these are certain examples for drugs causing CIAD. And lung diseases. Lung diseases can also lead to CIAD. That include tuberculosis, lung abscess, and acute respiratory failure. Acute respiratory failure. Now about the criteria for diagnosing CIAD. Criteria for diagnosing CIAD. As we already discussed, syndrome of inappropriate ADH secretion is a hypotonic isovolemic hyponatremia. So the serum osmolality, it's a hypotonic condition. So serum osmolality will be less than 275. That is one of the criteria. But the urine osmolality will be elevated because of the secretion of sodium. It will be, and increased reabsorption of water also. It will be more than 200. Okay, and urine sodium also will be elevated, typically more than 20 milliequivalents per liter. Okay, and the other criteria, these are the main criteria, and other criteria include there will be clinical euvolemia. Okay, and there will be normal renal, cardiac, hepatic, and thyroid functions. That is, hyponatremia cannot be attributed to any other system involvement. Okay, so these are the diagnostic criteria for syndrome of inappropriate ADH secretion. Okay, serum osmolality will be less than 275, urine osmolality will be more than 200, there will be urine sodium more than 20, clinical euvolemia, and other organs will be within normal limit. Okay, that's all about the discussion about hyponatremia, and hope you enjoy the video, and kindly consider the subscription of my channel if you are interested in emergency medicine related videos. Okay, thank you for watching.